audience, moderator, welcome you all in my presentation. My topics, OCT with Angiographic Co-Registration increase PCI Outcome. I'm Dr. Abdul Kayum from National Heart Foundation Hospital and Research Institute. OCT, intercoronary image, can provide detailed information on coronary plaque morphology, other lesion, and vessel characteristics, can potentially lead to further optimization of percutaneous coronary intervention strategy. Intercoronary image also provide accurate lesion delineation and precise measurements for sizing and positioning of coronary stents. ACR, during percutaneous coronary intervention, it may be challenging to identify the corresponding segment between the intercoronary image and angiography. Computer-based online co-registration may aid to target the segment identification. So aim of this study, longitudinal geographic mismatch as well as edge dissections were associated with increased risk of adverse event after percutaneous intervention. Real-time OCT with angiographic co-registration is available and allow much integration of cross-sectional OCT image to angiography. Aim to impact of ACR for PCI planning and risk of longitudinal management, longitudinal mismatch, and edge dissection. So, patients with clinically significant stenosis, at least one coronary artery stenosis were enrolled in this study. Pre-post PCI strategy were prospectively assessed after angiography. OCT and ACR data analyzed. I want to show some case to you. My first case, Mr. AX, 49 years old, recent MI inferior hypertension diabetes, ECG inferior MI, ejection fraction 48%. This is angiography. You can appreciate the proximal segment of RC is tight stenosis. So we measure the QC, and you can, this is the length of stenosis from here to here, shows 20 millimeter. So we done the OCT. You can appreciate the nice picture of the OCT. And this OCT and ACR, you can show the ACR shows length is 37.2. QC shows 20 millimeter, but ACR shows 20. And also OCT describes the morphology of the vessel lesion of this. So we changed our decision, and we took 3 into 38 millimeter DS and deployed into 12 atmosphere. After that, again we checked the OCT, and it found stents are nicely opposed to the, and no longitudinal mismatch, no malopposition. This is the final result. My second case, Mr. Y, 56 years old, chronic stable angina, hypertension, DM, with ECG normal, ejection fraction normal. This is right coronary artery tight stenosis. Again, measuring the length, it is found 19 millimeter, here to here. So we cannot pass the OCT catheter. So we pre-dilated the lesion in 2 into 10 millimeter NC balloon. Then with the OCT and sorry. Can you back the previous slide, please? Yeah, thank you. So this OCT shows, ACR shows again the 35 millimeter. So again it changed the decision. So we take the 338 millimeter stents and deploy 12 atmosphere. After that, we check the OCT, and it founds again some the under expansion of the stents and some malopposition, red mark, the under expansion stent malopposition. So we decide for post dilatation into 3 into 12 millimeter NC balloon in whole length. After the check OCT, the stents are well opposed except that area. You can appreciate this under expansion more than 4 millimeter. So we change our decision and take the high size balloon, 3.5 into 10 millimeter, and then the final result. So in our point of view, in 84 cases, OCT with ACR significantly altered the treatment strategy. The use of ACR reduced the longitudinal mismatch, and post-operative OCT demonstrated edge dissection, under expansion, malopposition, tissue or thrombus prolapse, incomplete coverage, thereby requiring additional intervention for optimization. So this is pre-posterior OCT changed the decision 76% cases, and ACR changed the decision 23% cases. Overall decision changed by 83% cases in our study. So OCT results overall 76% and real-time ACR additional 23%. So this result, we can say the OCT with ACR significantly improved immediate and long-term outcome of PCI intervention. Thank you for all.